Good afternoon and welcome to the November Health Policy Grand Rounds of the Philip R. Lee Institute for Health Policy Studies. I'm Joanne Spetz and I'm the director of the Institute, and I'm very excited that we have today Dr. Stacie Dusetzina as our speaker. Dr. Dusetzina is a professor at Vanderbilt University. She's an associate professor in the Department of Health Policy and an Ingram associate professor of cancer research at Vanderbilt. She is a health services researcher, and her work focuses on measuring and evaluating population level use and costs of medications in the United States. Her research has been really instrumental to building the evidence base for the role of drug costs on patient access to care and policy changes that might improve patient access to high-priced drugs. She's been recognized for her work at a national level, including being an invited participant of 2 working group meetings on patient access to affordable cancer drugs hosted by the President's Cancer Panel, and being selected to co-author a National Academies of Sciences, Engineering, and Medicine report on that same topic. Her research has been broadly covered by the New York Times, NPR, Washington Post, Stat News, and other news sources. So I am very pleased that we have her here today, and moderating our question and answer today will be Dr. Sanket Dhruva. He's an assistant professor of medicine here at UCSF in the Division of General Internal Medicine. He also is an affiliate of the Institute and does his own research around medical device and drug safety and cost issues. So he's going to be the perfect moderator for the Q&A. If you have any questions, please put them into the Q&A box that is visible on the bottom of your Zoom screen. And then when we get to the Q&A portion of this presentation, Dr. Dhruva will be moderating that. So without further ado, I will hand it over to Dr. Dusetzina for our presentation.
Great, thank you so much, Joanne. It's a pleasure to be here today. Let me get things pulled up. So today I'd like to spend time talking about improving access to prescription drugs, which is the thing I like to talk the most about. But specifically, I want to talk about Medicare Part D. I'm not an economist by training, but I do go to a lot of talks given by economists, and I've decided I like the way that they tell you what they're going to tell you right up front. So we're going to cut to the chase, and I'm going to give you a quick summary of where we're headed. So we're going to talk today about how Medicare Part D coverage is not adequate for covering high-cost drugs. And I'm going to give you a lot of examples of how this works for people needing to fill drugs for treating cancer. I'll also talk a little bit about the history of the Medicare Part D program. We've had a couple of major changes in the program since it was first conceived in 2003. And some of those changes have actually created more problems than they have solved for people needing high-priced drugs. And I'll argue that we have significant access issues today. And I want to talk then about some of the policy options that are on the table, and specifically some of the policies that are under the Build Back Better agenda that is hopefully moving forward in the near future. So I want to do a little bit of level setting around the prices of cancer drugs and what's happening to new drug prices over time, and also what's happening along the lines of price increases for existing products. So this is some work we did a couple of years ago looking at drugs in the Medicare Part D benefit and when they were first observed in the benefit and how high their prices were for an average fill. So each bar in this graph represents several drugs, and drugs are basically ordered based on the first time we saw them in the Medicare Part D program, starting in 2010 and through 2018. And all of these bars have been adjusted for medical inflation. So if the prices were stable, you'd expect them to stay roughly at about this $8,000 mark per average fill. So this is an approximate 30-day supply cost. But what we see over time is that as new cancer drugs are entering the Medicare Part D benefit, we see that their prices are set higher and higher. Today, it's not unusual to see some of these drugs priced at over $20,000 for a 30-day supply. And that price is the price that Medicare and the plans pay together, or Medicare and, plans and the patient pay together. Now let's talk about what happens with the same drugs over time. So these bars, though they look very similar to the prior graph, these are actually the same sets of drugs represented in each bar. So 2010 through 2018, we had 13 drugs that were available in all of those time points. So this shows you, after adjusting for inflation, the price increases that are occurring among the same products. These are not new innovations. These are the exact same drugs. And what we're seeing is that prices for those drugs have increased from an average of $6,000 per fill to about $14,000 per fill in 2018. So two combined forces here, where when new drugs come onto the market, they're priced higher than drugs that came onto the market before them. And we're seeing price increases well above inflation for drugs that already are available. So I want to talk a little bit about the Medicare Part D history. And I've broken it up into 3 different time periods to represent the standard benefit at these different phases. So 2006 was the first year that the Medicare benefit was available. And 2010 represents once we've passed the Affordable Care Act and some significant changes that occurred. In particular, with the Affordable Care Act, we saw the donut hole close. So I'm calling the 2006 to 2010 era the donut hole era. And I'll explain a little bit more about what that meant for patients. With the Affordable Care Act, the donut hole was closed. And then with the Bipartisan Budget Act, we saw a few additional changes, which I'll go into. So at first glance, you might think this looks a little bit complicated, and you would be right. So the blue boxes represent what patients pay as they move across the benefit. And to make this a little bit more simplified, I have deleted the deductible phase where the patient pays 100% of the drug's price until they reach a certain level of spending. I delete this because it's the first thing that you get. It would be on the far left side of the graph if it were visible, but a lot of people enroll into $0 deductible plans, and the deductible tends to be kind of at the worst case, just under $500 in more recent time. In general, though, the benefit is complex for people. It is broken down into multiple phases. And so beneficiaries basically are responsible for paying approximately 25% of their drug's price until their drug spending reaches the coverage gap. And this is approximately $4,500 in spending in more recent years. But those price points have changed over time. And that's why I don't have them all represented here. But patients, then once they reach the coverage gap or the donut hole, they would have to pay 100% of their drugs prices until they have what we call a catastrophic level of spending. Now, today's catastrophic spending level is about $10,000 in total drug spending. So that is quite a substantial amount of drug spending to get out of the coverage gap. But after people do, then they switch into a 5% coinsurance. This is the standard benefit, and the benefit can be adjusted and often is to have slightly more generous coverage. So for example, today, most people taking preferred brand name drugs and generics would pay a flat fee copayment in this initial coverage phase. But virtually everyone is exposed to the coinsurance offered in the coverage gap once they reach that phase. Now, you might be able to obviously see what's the problem here is that when you're taking medications to manage chronic disease, you suddenly go from paying, let's say, a flat fee copayment of $40 or 25% of your drug's price, and then suddenly you're asked to pay the full amount. This can lead to non-adherence of your medication. And in fact, studies that were conducted a couple of years after the benefit was in place found what they coined the January effect, which was basically that people taking medications for managing their chronic illnesses would suddenly stop taking them when they hit the coverage gap or donut hole, and then they would reinitiate those drugs in January once their benefits reset. So we've known for a long time that this donut hole or coverage gap is very bad for patients and for their adherence to their medications. So the Affordable Care Act worked to close the donut hole, but it did so in a complicated way. So rather than try to work through that, I thought Homer eating the donut hole or the donut would be about as good as I could get for demonstrating what happens. Basically, what happens is over the period of 2011 through 2018, originally planned through 2020, the Affordable Care Act aimed to reduce the amount that patients paid in the coverage gap from 100% out of pocket down to 25%. So once the donut hole was fully closed, it would basically extend this initial coverage phase up to just have people pay 25% of brand name or generic drug costs. Still, patients would have to pay 5% once they hit this catastrophic threshold, which means that they still may be responsible for quite a lot of money. And again, there's also no out-of-pocket limit on the benefit. But this is, by and large, a major improvement for people who are taking traditional generic drugs or lower cost drugs in the program. Now, I said it got a little bit more complicated with closing the donut hole. So today the benefit looks like this. The Bipartisan Budget Act that I mentioned earlier actually created an incentive here or created a change from what the Affordable Care Act had specified. So the Affordable Care Act required manufacturers to pay 50% of brand name drug costs in the coverage gap. The Bipartisan Budget Act increased that to 70%. So today's benefit, when someone's filling a brand name drug, they will spend 25% and then they'll spend another 25%. And manufacturers will pay 70% of that brand name drug's price during that coverage gap phase. Now, it's important to know that all 95% that is paid by the patient and the manufacturer helps the patient to reach the catastrophic phase faster. This is very different for generic drugs, where the plan actually pays for the difference between the amount the patient pays and the total. So for generic drugs, plans have to pay 75% in the coverage gap rather than only 5% for brands. Another thing that's important to recognize with this policy change is that for generics, this means that Medicare beneficiaries actually have to spend more of their own dollars out of pocket when they're filling a generic in order to reach the catastrophic phase. And this will come back later in a couple of slides when I tell you about some problems that that's creating. Because I think on its face, it sounds like a theoretical problem, but in reality, it can create significant financial problems for beneficiaries. So I want to talk for a minute about a couple of issues that have come up over time when thinking about policies to improve Medicare Part D. And one of the issues is that I think that because the people knew about the donut hole and what a problem it was for most beneficiaries when they went into the donut hole and had to pay 100% of their drugs prices, that there was a little bit of a sense that once the Affordable Care Act closed it, that solved some of the affordability problems for Medicare beneficiaries. And again, the situation for the traditional beneficiary that has maybe a mix of generic and a few brand name drugs over the course of the year, that certainly is the case. Closing the donut hole dramatically improved the affordability for those individuals. But for people needing high cost drugs, we see a really different dynamic. So this graph represents the cost of drugs that were available in both 2010 and 2018, taking into account that in 2010, the coverage gap was open and beneficiaries had to pay the full amount out of pocket for their drugs at that point. And then in 2018, the coverage gap was fully closed. So even though we know the Medicare Part D benefit got much more generous over that time point, what we see is that basically beneficiaries are paying more out of pocket for the same drugs in 2018, even after the benefit got more generous. This is because of price increases for the drugs that are shown here. So even though we see the benefit improving, price increases completely erase the savings for people taking high-priced drugs. The other thing that I think is important to recognize is that when you ask people about how to start to spend less on prescription drugs or make medicines more affordable, one of the very first things that people mention is increasing access to generic drugs, making sure they're available more quickly, and increasing competition in that market. And I definitely agree that that is a huge, important thing to be doing. However, I think that a lot of times our recommendations are based on the knowledge that we have generated over time that is relevant to drugs that are used to treat large patient populations. So when we think about generic entry and what that means for drug prices, we often think about statins, for example, where we have a very large market of patients to be treated, and we have many, many companies who are making generic statins. So we know that the price for those drugs drops very, very quickly after the first generic entrant has lost its market exclusivity. This is an example of generic entry for a cancer drug. So this is for Gleevec. It's generic imatinib. This is the best cancer drug we have. And for people who have this particular type of leukemia, they need to take Gleevec forever. And they need to take it as, be nearly perfectly adherent to maintain the benefits. So this is a really important drug for medication adherence. And we also know it's an important drug for people to be able to afford. So what you see here is that when the generic came onto the market back at the end of 2015, the price for the annual treatment is very similar to the brand name drugs price. So we don't see very large price reductions. Typically, what we would expect is about 6 months after the first generic was observed that we would see the price decline. But we don't see the price decline until several years later. One of the issues here is that generic entry is somewhat more limited for drugs that are used in the rare disease context. Other studies have shown that the average number of drug entrants for generic manufacturers is 3.5. However, the FDA has said previously that we need 4 generic manufacturers to get robust price competition. And in fact, that's exactly what we saw here, where we had 3 generic entrants before 2018. And once we got that 4th generic entrant, we started to see real price competition. But having at least 4 generic drug manufacturers enter the market is not guaranteed. So it's, there could be other cases where this is shorter or longer than what we observed. Nevertheless, over time, we eventually see some savings on the generic relative to the brand. The really bad news for patients is that they don't really get those savings for a very long time. And even though the savings to Medicare are fairly large when you compare the price of imatinib versus the price of Gleevec in 2019, for example, patients are still paying more for the generic than they are for the brand under the Part D benefit, even through 2018. This is a factor related to that coverage gap discount that I showed you in the current Part D benefit. So this is a result of the generic having a high price or not having as much of a price reduction as we would have liked to have seen, but also because there is no manufacturer discount that helps the patient to reach the catastrophic phase of the benefit faster, which means that patients do have to spend more of their own dollars to reach the catastrophic phase. And ultimately, it means they're paying more for generics in this case, at least through 2018. And even in 2019 and 2020, you see that beneficiaries are still paying over $6,000 a year for being treated with imatinib. This is incredibly disturbing on multiple levels. A couple of key reasons. One is that Medicare Part D plans did very quickly shift to offering only the generic. Typically, we would think that is a very good idea. But for the actual beneficiary on the plan, it might mean that their price went from about $8,000 a year to over $10,000 a year once they had to switch to the generic. The other thing that is a very challenging aspect of this is that many people with cancer will use patients' assistance programs to help cover their costs. And those programs are not funded by companies once a generic comes onto the market because they're not able to steer people to use the brand only. They are funding a disease area. This is how they're allowed to provide these sorts of financial contributions to Medicare beneficiaries. So they'll stop funding the disease area once they face generic competition. So for someone who has cancer and is taking Gleevec and needs to switch to imatinib, they could face much higher costs and lose copay support options for helping to manage their drug costs. So this is an example of a situation like this, not the generic and brand, but this is an example of an individual who is aging into Medicare and who is receiving cancer treatment. And this vignette talks about how John Crane and his wife were making a decision to delay his treatment for metastatic disease because he'd have to pay $3,200 for the drug in December and then another $3,200 in January. And it was the first time since he'd been diagnosed that he decided to delay filling his medication because of this concern that he couldn't afford to do so. And I think it's important to recognize that this is not just that John has a bad Medicare Part D plan. This is an example of the most generous Medicare Part D plan available in Nashville. This would look the same anywhere in the country for filling the drug that John is trying to fill. Now, all Medicare Part D plans have to cover cancer drugs. So these are protected class drugs. So this isn't an issue of the drug not being on the formulary, but this is what it looks like when you're trying to fill a drug that has a list price of $20,000 per fill. It results in you having to pay over $3,000 for your first fill and $1,000 thereafter through the end of the benefit year. This is the benefit design facing most people. In fact, it's roughly $15,000 over the course of the year when you add it up. So I want to share a little bit of information from a new study that we've conducted that's under review currently, where we took information from people who had received a prescription for a new orally administered cancer drug from one of 11 different medical centers in the US. And we linked their data to fee-for-service Medicare claims to try to understand whether or not they were able to fill their prescriptions that were written for them. So these individuals received one of a variety of cancer drugs. We made sure that they were treatment naive, so they didn't have prior records. And then we looked to see, did they fill it in the 90 days after the prescription was written? And then we also looked to see, did they fill anything else that could have been a substitute if they didn't fill the drug of interest. And we found that 1 in 3 people with cancer who had a new prescription for a drug covered under Medicare Part D did not go on to fill that drug. We also looked to see if they filled it within 180 days and also found no additional people filling in that timeframe either. Now, we wonder to what extent this 1 in 3 is being driven by potential concerns around costs. And in fact, we do find that not starting treatment is about twice as likely among beneficiaries who lack out-of-pocket cost subsidies. So when you don't have a subsidy, your price for one of these drugs is at least $1,000, but potentially $2,000 or $3,000 out of pocket for your first fill. If you do have a subsidy, in particular, if you have full Medicaid, your price is $9 for a fill for a brand name drug. So you can see that there is a very significant difference in the probability of leaving your drugs behind at the pharmacy if you don't have a subsidy. And I think it's really important to think about this in the context of how Medicare beneficiaries experience these subsidies. About 2/3 of Medicare beneficiaries do not have subsidies, but even among that group, the median income is about $30,000 a year. So we're talking about a group of people that is not wealthy and may not be able to afford these treatments. So Medicare Redesign has been proposed as an option to try to deal with this affordability challenge. And I will talk quite a bit about the current state of this in just a moment, but I want to talk a little bit about the redesign proposals that have been advanced. So this study looks at 4 different bills that have been advanced between 2019 and 2021 that work to redesign the Medicare Part D benefit. So for each of those, I've estimated spending on the benefit across the top 15 highest spending drugs, and these are ordered by their prices. So you can see on the far left, these are drugs that are brand name drugs that cost about $500 per fill as the total price. So beneficiaries are generally paying about $100 per fill or a bit more. And then over to the far right, we start to see cancer drugs as the primary drivers of these highest spending drugs. Now, Medicare redesign proposals that have been advanced are very similar to one another in their designs. So most of them do a couple of things. One is that they streamline that multi-phase benefit, and they just say, we're going to have one long initial coverage phase, and we're going to apply a co-insurance of maybe 20%, 25%, or 15%, depending on the bill. And all of them also add an out-of-pocket maximum to the benefit. Most of those prior bills used a $3,100 out-of-pocket maximum, but HR3, the gray dots here, use a $2,000 out-of-pocket maximum. And what we find is that for people who are using very expensive drugs, they would save 70 to 80% relative to the current day benefit if we did a Medicare redesign that included an out-of-pocket cap. So this is a huge amount of savings for somebody needing cancer treatment. And it's a very large benefit for people who maybe aren't currently using the treatments, but who may be one day needing to use them. So before we move into the Q&A, I want to talk a little bit about where drug pricing efforts are today, because it has been a moving target. And I just pulled a few tweets from October 28th and 29th. So as I'd say a Medicare Part D enthusiast and someone who closely follows this issue, I was despondent when there was a concern that drug pricing reform was completely left out of Biden's reconciliation framework. That's the center tweet. So when President Biden came forward with his framework, he had completely removed elements that included drug price negotiation and Medicare redesign for his framework for the Build Back Better Act. However, very shortly thereafter, it seemed that those pieces may come back in a modified way. And after a lot of negotiation, we did see that drug pricing, both drug price negotiation and also Medicare redesign have come back and are now currently part of the Build Back Better plan, at least as of last night. We'll see how things evolve in the coming days and weeks. But right now, the proposal would negotiate for some drug prices, a limited set, but more importantly, I think, at least for beneficiaries and their access, it would cap the benefit at $2,000 per year. It would potentially offer the ability to spread that $2,000 out over the year for some people, depending on when you fill the drug. And it would limit drug price increases to the rate of inflation, at least for Medicare beneficiaries. So these are some really important steps in making drugs more affordable for beneficiaries. They do leave some room, which hopefully we'll be able to discuss, for potential price increases, I think, in the industry. But by and large, I think would be a major step forward in drug policy and would solve many of the problems I have presented today, including that nasty problem about making generics more expensive than brands. So with that, I'm going to stop sharing so that we can have a discussion.
Thanks so much, Stacie. That was a really informative presentation. Thanks so much for sharing a lot of important work that you've conducted, and as well as sort of bringing us up to speed with the ongoing negotiations and back and forth in Congress. I want to first just start by asking a key question. It seems like one of the crux of what you shared with us is that prices for drugs are getting higher and higher. Let me just ask you the overall question: are the drugs getting more and more effective or more safe? Is there justification for the price increases? Are these helping our patients live longer and live better?
So I'd say by and large, no, at least not in the cancer context. So, maybe I'll point to a recent evaluation of the oncology care model as one hint at how things are going over time, where the authors looked at, and this is a model that was running in the Medicare program, and looking at care coordination for people receiving anti-cancer treatments and looking at differences in outcomes around treatment episodes. And they looked at median survival among individuals with kind of higher risk cancers. And over the 3-year period of observation, they found that drug spending increased pretty substantially, but survival time on average, or median survival time, did not look like it improved by more than 5 or 6 days over that same period. So we're looking at literally thousands of dollars in increased drug spending and days of benefit. Now, I will say that it is complex because there have been some treatment innovations that have really made a difference in some clinical areas, but by and large, there are probably more that have had very incremental benefits than there are that have been home runs.
That's really helpful. All of us generally assume if you pay more, you're going to get more of a benefit. And it sounds like we're getting on the margins, maybe a few days, and hard to understand why that's happening. Can you talk a bit about in general, in recent years, the FDA has focused on approving drugs more rapidly, expediting approvals. More drugs have come to the market through accelerated approvals as breakthrough therapies, et cetera. Now, these drugs, as they come to market, for example, accelerated approval drugs, which I believe, I imagine it's for many of the cancer drugs that you shared with us here this afternoon, will come to market on a surrogate endpoint. That is one that need not definitively show clinical benefits. In fact, very rarely will be proven to show clinical benefits. It might be that a tumor size is regressing or that there's no progression in a tumor, as opposed to if a patient with a given malignancy lives longer. Are there any considerations for the prices of these drugs being lower until some clinical benefit has been demonstrated or proven? Do you have any thoughts on this? It seems like a really tricky topic, but since FDA has to approve a drug before it can be covered by Part D or other payers, would love to hear your thoughts on that topic.
Yeah, so this is a very tricky area because, the accelerated approval program really is trying to meet unmet clinical needs. So there is kind of this tension between wanting to get drugs out to the public faster when there is an unmet need, and then the tension of having maybe less evidence than we would like at the time of approval. So then we need to wait and generate more evidence. There's definitely a lot of discussion from public payers about how to manage spending on these drugs. So this includes Medicaid programs as well as Medicare in thinking about how reimbursement should be set. And there are a couple of issues baked in there. One is that we don't know how good these drugs are, or if that surrogate endpoint will translate into real outcomes that matter to patients. And so there's a question of, should we still pay these very high prices with that uncertainty? And the other issue is that there is a lack of incentive for companies to quickly complete their studies and demonstrate, get to the outcomes that matter if they can sell their drugs at a very high price without having to show those benefits. So MACPAC and MedPAC have had conversations about how to create the more incentives around reimbursement, and whether that be that a rebate is paid to the program when studies are not done in a sufficient time frame, or potentially thinking about having the ability to use maybe a value-based price for drugs during that time when they're on the market, but before their clinical benefits are demonstrated. So these are very, very active policy discussions about how best to manage them and how to align incentives so that, patients have early access, but that we all have incentives to get the real answers that patients and their family members actually want to know too. No one wants to take a drug that may be ineffective.
Absolutely. Thanks, Stacie. We have a question related to why do you think, or do you have a sense of perhaps why drug pricing was initially taken out of Build Back Better? And what's also your level of confidence that this will be a part of ultimately the bill as the negotiations continue?
That's a loaded question. I think so there's a lot of industry money that floats around for members of Congress. So there's actually quite a lot of people getting paid handsomely by the industry. And I think we can't minimize the importance of those dollars in having policies shaped in the way that are industry friendly. There's also a lot of contention, even among Democratic members, about this real concern around innovation and access to drugs. So, people who are quite sensible about the topic do recognize that if you make extreme changes to how we pay for drugs or how much we're willing to spend on drugs, that we may see some level of drug development reduced. So we may lose some innovation. And we don't have very good evidence on how much innovation we might lose. The CBO has created some analyses, but most of the empirical evidence is from expanding access to health insurance. And so we don't really have a example where we can say, here's exactly what will happen and how many drugs and which drugs will lose. So I think those arguments end up resonating with people, and especially in a time where the industry has stepped up and created vaccines and treatments for COVID that have been really innovative and important. And so I think that that has created enough concern that what was originally proposed was too extreme and got pulled out. I am hopeful, or at least I believe that, knowing that that would never fly. So that I think is why Biden pulled it out. But I think then seeing people's reaction that we still need to do something, we can still do something meaningful. I personally was devastated the idea that we might lose all of these important changes. And so I'm very pleased to see that it came back. I think given the amount of interest in it and the response for having lost it before, I would be really surprised if it goes away again. And I'll say the other thing is that a lot of those provisions have previously, we're waiting for CBO to do their scoring, but like a lot of them have previously been assessed as being cost savings. And so that may give them a better chance of getting through the reconciliation process.
Great, that's very helpful. Near the end of your presentation, you worried, I think, all of us a little bit because you mentioned that there is also some room for price increases. Based on what you've seen in Build Back Better, there's some room for price increases a little bit later. Can you explain a bit more about what that means and what that might look like?
Yeah, absolutely. So, for the drug price negotiation that is included in Build Back Better, it focuses on negotiating a price for starting with 10 drugs that have ended, basically reached the end of their original exclusivity periods. So for small molecule drugs, that would mean that they can't be negotiated until they've been on the market for at least 9 years. And for biosimilars, I think it's 13 years. So the drugs that are subject to negotiation are really different than when we were thinking about drug negotiation under something like HR3, which was the original plan, which was just let's negotiate for the most expensive drugs, the ones we spend the most on. Because of that, and also because there will be limits on drug price increases to the rate of inflation, there could be a response by the industry to raise prices on most of their products and potentially to start with higher prices when they launch new drugs. And right now, I don't think, aside from head-to-head brand competition, I'm not sure there's much we could do about that. So I think that's going to be something we have to watch carefully. The other concern is that capping out-of-pocket spending on Part D does create another challenge in that there is no longer that price sensitivity. So I showed you that 1 in 3 Medicare beneficiaries is not filling a new cancer prescription that is given to them. So if most of that is cost-related non-adherence, we may see a big jump in the number of people filling those drugs because they're no longer priced out. I would argue that's a really good thing. I don't want people not filling their cancer drugs because they can't afford it. That's unbelievably unfair. But I think that there is the reality that if people are no longer price sensitive and the drugs have mandatory coverage, it will be surprising if those prices don't further increase.
That's really helpful. These unintended consequences that we'll have to be keeping an eye out on, and which could certainly have dramatic consequences for many years for many beneficiaries. Thank you. I think we have a question from Dr. Rita Redberg. Dr. Redberg? Okay. I think, Dr. Redberg, I think you may need to type it in the Q&A box. I think the way that we're set up, that might be necessary. While Dr. Redberg is putting that together, I was hoping, Stacie, that you could answer a question related to patient subsidies. You mentioned that manufacturers provide subsidies for patients. Certainly the data that you presented that you've been working on recently showing that patients are not filling their medications because of high out-of-pocket costs are concerning. Can you talk about what, at a high level, patient assistance programs are available to Medicare beneficiaries and how things might change? So what the implications of those are for drug prices and for patients and how things might change?
Sure. So there are a lot of different foundations that receive funding from the pharmaceutical industry to set up copay support programs, but they are set up as disease funds. So Medicare beneficiaries cannot use coupons and they cannot use manufacturer assistance directly, but they can apply to receive funds through foundations. So for example, the Leukemia and Lymphoma Society is a commonly used resource for people with blood cancers, and they can apply to receive a grant to help them with their costs of transportation or, parking fees or drug costs. So it can be used for a range of things. The pharmaceutical companies will provide funds to those organizations to be used to support those types of expenses. And I think, ideally the companies would like those funds to be used to help offset costs of the treatments to allow people to fill their medicines. There are a lot of challenges. One is do you know that these programs exist? Do you have help applying? Do you fit into the income restriction criteria? And even things like when in the year were you diagnosed and does the fund still have money? So a lot of these funds really struggle with having so much demand that they run out of money during the year. So if you got diagnosed in November, the fund may not have enough money to provide you with support until it gets refreshed in the next calendar year, for example. So these are certainly a necessary evil at this point. If you talk with people from assistance foundations, they often say that they wish they weren't required or necessary because they understand that in some ways they allow for high prices by having this money funnel through and pay the patient's cost sharing. But at the same time, we know that people can't really afford their medicines and the benefits don't support access to drugs. So right now, I think they really are kind of a necessary evil in the system, and one that does provide a lot of benefit for patients who are able to navigate the programs.
Just seems like it takes a lot of resources, and it's helpful that you characterize them as a necessary evil, a tricky situation. We have another question from Dr. Grace Lynn. Since federal legislation for drug pricing is tricky, are there other policy levers that could be used to push for more value-based pricing, particularly for drugs where the clinical benefit hasn't yet been demonstrated or where it turns out the benefit isn't actually as great as we hoped?
Yeah, it's a very good question. And I spend most of my time thinking about federal policy, partly because when states try to act, it creates additional gaps. So I've done some work previously on cancer parity laws and on specialty drug spending caps. And the biggest challenge with those are that, they apply to a subset of the population. So for example, they'll apply to people in fully insured private plans, but they don't apply to people in those same states that are in self-funded plans, which end up often being more of the population. So in some ways, I find it very tricky when you're thinking about which lever to pull. Maybe you can get more innovative policy designs in the state, but then the state only has a limited reach on how many people can benefit from those policies. I think they're still very important to do. But even at the state level, there can be significant pushback. I will say, anecdotally, I remember traveling in California when I think it was Prop 51, but I could be wrong about the number now. It's been so long. It's been where there was an effort to negotiate prices for the state for their drug pricing. So the state wanted to lower spending on prescription drugs. the number of billboards and TV ads, that the pharmaceutical industry launched on the state were just incredible. It was like traveling through the area and watching TV there. It was like, what is happening? And it was so persuasive that people voted against trying to lower prices for the state, negotiating drug prices, which is something that is wildly popular when you ask the public. So I think that it's very difficult to make inroads in this problem in general. I know there are some efforts in different states to try to do so. And I think that they should continue. I think that I'm hopeful that even trying to start the conversation, let's say Build Back Better, fingers crossed, moves forward. I think opening the door to drug price negotiation in any way in the Medicare program is such a massive step forward that it maybe will allow for more conversations about value to start to creep in. I think we absolutely have to have those conversations, and I think we can get there. It will take time.
That's very helpful. Hopefully this is step one, even if it's a baby step in that direction. Thank you. And here's the question from Dr. Redberg. It seems like a lot of the problem with high drug prices, both initially and then the increases, Stacie, that you showed, and the current system are built to preserve the high drug prices through mechanisms like coupons, for example. What do you think would be the most effective way to address this, ideally, and make a difference, the real practical solutions in the upcoming year in 2022?
I don't know if it's going to sound practical, but I'll tell you, the thing that I think is most logical from my perspective is to address areas where we know that we don't have competition because of the way that we have designed our policies. So what I think we should be doing, for example, in Medicare, is when we have a protected class like cancer drugs, where we have required formulary coverage, or when we have drugs that have a special approval like accelerated approval drugs, I think we should have more control over the pricing of those products, acknowledging the fact that we have created a system in which competition doesn't exist, and we can't just have people name their price once we have guaranteed coverage. I also think, as a person who, believes very strongly that the amount of money that people pay can't be endless, people and Medicare, taxpayers, all of us who are insured, it can't just be endless. I think we all really want to know what is a good value for our money. And so I think that trying to keep pushing this message of value and why we might want to know what a value-based price is for something is another important thing. In the cancer context, it would be very, very helpful to understand the real benefits that are being offered by treatments. And even as a person who studies this area, I find it very difficult to disentangle when is a drug really worth it? What does progression-free survival really mean? Why don't we have better information on quality of life and not just, the size of the tumor? These are things I think we should be working towards. And even though they're hard, I think even more conservative individuals could agree that when we have created a system that doesn't allow for competition, that we then maybe should use that as a place to do more intervention.
That's really helpful. Do you think that things need to move upstream to the level of, for example, FDA evaluation of new drugs?
I think not the pricing part. I think that, FDA does have a very specific mission around the effectiveness and the safety of drugs. I think that's incredibly important, and they need to do that job very, very well so we can have confidence in the results we get back. I will say, as someone who works with ICER and does evaluations of the evidence when a drug is coming to market, I think that one area that is in real need of in need of improvement is how outcomes are captured. So if you have a drug that is similar to another drug, but you always measure the outcomes in different ways so that they're not really truly comparable once we have those trials finished, that is incredibly frustrating for thinking about doing comparisons of the cost effectiveness, because the outcomes aren't measured the same way, or maybe they're not using validated measures. And we see this a lot with some of the rare disease treatments. I would say that if I could ask one favor, it would be for more standardized measurement across products that are being used in similar ways, and also more attention paid to including quality of life measures in addition to other measures of drug effectiveness.
That's very helpful. I imagine that manufacturers are not incentivized to support the generation of comparative effectiveness and comparative safety data. But it sounds like perhaps that's a role that FDA can take.
Absolutely.
That's very helpful. I think, and we had a similar question from Dr. Redberg about other data that FDA should acquire prior to approval as well. And I think you've really hit on that. So I think that we're at the end of the hour here. Dr. Dusetzina, we can't thank you enough for really insightful work, really literally on the pulse of what's happening in Washington, or the battles that are currently being fought. And we'll look forward to thank you for helping to inform us, and we'll look forward to seeing what happens and look forward to learning from your writing in the near future.
Thank you so much. It was a pleasure to be here and to talk with you today, Sanket.
Thanks so much.